now we can move ahead. So just want to notify folks we are recording this, and you can have access to the webinar off of our website in the future. Next slide, just a quick disclaimer. What you're hearing today represents the views of Infoway. It's designed to be for your information only. It doesn't represent necessarily our future strategies or investment criteria. We may, in the course of the presentation, mention vendors, and we're not here to explicitly or implicitly endorse any particular solution or vendor product in that context. Very quickly about the Emerging Technology Group, just to give you a little context as to what we do. In this slide you see our mission and vision statement. So our role is to really identify, assess, and promote viable and disruptive emerging technologies in the context of healthcare. And so we'll always look at these in that context. So for example, with big data, it's not just about big data, but how could it or should it be used in a healthcare context. Then we try and drill that down into a Canadian context, and in specific areas, drill that down into an e-health or digital health context as well, to provide as much information as possible to our stakeholders around the country. Where appropriate, and you'll hear some of that today, we look into privacy and security aspects of these technologies as well, since that is front and center for all of our stakeholders. So our vision, very simply, is emerging technologies are appropriately and effectively used in promoting the health of Canadians and the sustainability of the healthcare system. Our lead investigator on this particular topic was Alex Mair, so I'm going to introduce Alex. He is the Group Director of Architecture in the group, focusing on topics such as big data analytics, the secondary use of data in healthcare. So he is going to lead us through this particular topic. And when we get to the right point, I will moderate the questions and my answers them myself or pose them to Alex, and then we'll take it from there. So please get your questions ready and type them in the Q&A box as you think of them. Thank you very much. Over to you, Alex.
Great. Thank you, Dennis. I'm assuming that I have video control now. So thank you, Dennis, and good afternoon, and welcome to the Emerging Technology webinar on big data analytics in healthcare, and specifically in Canada. I hope you've had the opportunity to read the white paper, and hope today's session provides enough of an overview of BDA and an opportunity for you to discuss and me to answer any questions you may have on the white paper. The agenda for today's presentation, as you see, is an overview of the BDA paper, a definition of BDA and the characteristics of BDA, and then we'll talk about what the economics and opportunities are for healthcare in Canada, and provide some examples specific to healthcare, both in Canada and outside of Canada. We'll also discuss Infoway assertions around what the challenges and considerations that people need to take into account for moving forward with BDA. And we'll wrap up with stakeholder readiness and a call to action for moving forward with BDA in Canada, and finalize with sort of a summary of some key points that we want to leave with you. We will close off the presentation with questions and answers. So this is the second paper in the Emerging Technology White Paper Series, as Dennis mentioned, designed to address big data analytics from a Canadian healthcare perspective, and really intended to provide some insights on its potential applicability of this technology, as well as context for what the opportunities and challenges are in healthcare, and particularly in Canada. And an encouragement, hopefully, for how to advance forward if stakeholders decide to move forward in this space. We felt it was the right time for producing a white paper on BDA for a few reasons. One is there's a lot of hype that exists in the industry and in IT in general. And the second is that we feel it is an emerging technology that should be taken seriously for use in the healthcare sector. It represents new sources of data, new digitized health information that were not previously possible to analyze, and it also has potential to provide new insights and value for addressing patient quality, safety, personalized care, and cost reduction and sustainability. It also is being driven by several models around that have created the ability to enable things around big data analytics. So cloud would be an example, software as a service, and mobile computing are really creating new demands and opportunities for accessing data from anywhere by any authorized user, anytime, from a variety of devices. We also think that and hope you agree, that the intent of the paper isn't to depict that big data is all good. The paper recognizes that there are risks, barriers, and challenges that come with all new types of technologies like big data analytics that will either enable or slow down the adoption of these technologies. So big data is really defined by new sources of data that have sort of three very key characteristics called the 3 V's of BDA. And those characteristics are volume. So volume is we moved from terabytes now to zettabytes. So just a few years ago, terabytes was considered large. And we've moved in just a couple of years past petabytes and into exabytes, and now we're into zettabytes. So this information is being created daily and weekly and is continuing to grow by leaps and bounds. On the velocity side, we're moving from traditional batch and transactional collection of data and supporting that for analytics through extract, transformation, and load processes to concepts like live streaming of data directly from devices and other real-time sources and performing analytics on that information. And then the last perspective is variety, new and existing types of unstructured data that are being created more and more each day. So these data have really created a new demand for cost-effective, innovative, and new forms of processing of this data. And being able to combine this data, combine previously siloed data, and manage voluminous and real-time data for new uses for stakeholders. However, big data by itself or existing by itself is really no value unless you have the analytics or the processes that are going to be required to generate value and context for stakeholders. All of this data and the processing that needs to be done for it is of little value if we can't visualize and provide context to stakeholders. And this is another V, which I call visualization, which is going to be critical in contextualizing this tsunami of data and turning that data into value and actions for stakeholders, specifically in healthcare. So big data is different from a term people are now using called small data. This is a term that has evolved just recently that really refers to traditional business intelligence or data warehousing or analytics. The key differences really start from big data and small data with the data collection differences. So the information management processes are very different than traditional information management processes for small data. The collection processes for big data analytics are organized for discovery, for mining, for looking for discovering relationships between data, whereas typically for small data, traditionally that information hasn't been unstructured. It's been more known and focused on modeling to organize known data for analytics. Also, on the analytics side, the approaches are quite different from big data and small data. Big data is experimental, discovery-based, systemic, and automated, and very much into the productive perspective of handling the 3 V's. Typically, it needs to be more systemic and automated because with this type of amount of data, end users just don't have the capability for mining this information, and we're really going to have to depend on IT or technology to mine this for us. Whereas traditionally for small data or traditional analytics, it's really that type of analysis has been initiated by end users, navigated by end users, and users are driven to go through that information to find the answer to the particular question that they have. And I guess another key point that I'd like to make is big data analytics doesn't replace small data or traditional analytics capabilities. It's really going to be complementary, and a lot of the big data analytics results is going to feed these traditional tools. So this slide highlights some additional key differences in the collection and information management processes between big data and small data. So the first is big data is really distributed, federated, very closer to the business, and really the raw data that big data is sourced from, whereas small data or traditional analytics, the location of the data, processes, and resources are typically centralized and usually centralized within IT. The second item there, big data is significantly unstructured and not modeled, and changes and is changing fast. Whereas traditional data or traditional analytics, the data has been fairly stable, it's modeled, and it doesn't really change that much. Small data is also very transactional based with known models and interrelationships. So we develop entity relationship models, schemas, and then we map those schemas to a target database or repository with technologies like extract transformation and load technologies. The next item is more, BDA is exploratory, so we need information management and collection processes that discover relationships that previously didn't exist. So BDA is now all about making sense of all this data, new sources, integrating unstructured multimedia data, whereas typically BDA, small data has been traditional analytics for known requirements, and statistical analysis has also been for known hypotheses. The last perspective is finally BDA needs to is going to open up, I think, a lot more opportunities for bringing in and integrating external data within the organization. So a lot of public data, weather, sensor, population, economic, open data are going to become more available through concepts like big data analytics, whereas traditionally small data or data analytics is focused on data within the organization or data maybe that's shared with partners. BDA also functions quite differently or brings a different type of analytics than small data would. So BDA is an experimental type of analytics, and statistical analysis is quite different in that we're answering known questions or known hypotheses. Traditional analytics requires aggregation, summarization, cleansing of raw data into a suitable form, i.e. dimensional models, for enterprise-wide analysis and reporting for predefined needs. Statistical analysis is, all the collection, organization, analysis, interpretation, and presentation of this data, but it's still addressing a known hypothesis. So big data is quite different from that perspective. Big data is also different as it's more of an open-ended how and why type of question. So BDA is discovery-based, it's using cognitive technologies, learning-based analytics, and it's really looking for patterns and relationships, and needs to be more systemic and predictive, whereas small data or traditional analytics are really designed to query specifically about what happened and where did it happen and when did this happen, and the end user is left to navigate through that data to find out ultimately why did this happen. Another perspective is BDA can process unstructured data to find patterns, whereas small data or traditional analytics can only process structured data that has been organized and aggregated specifically for analysis. And then the final perspective there is big data brings a systemic or automated type of analytics due to the 3 V's, whereas small data or traditional analytics is really user-initiated, navigated, and managed by the end user. BDA also brings some of its own unique characteristics. BDA is definitely characteristic of real time, so it delivers results or can deliver results faster than ever, analytics in real time. BDA scales to petabytes and exabytes today and will be scaling very soon to concepts like zettabytes. And BDA can process, generate, and index large sets of data across and outside of an organization. BDA can is also designed to function in a distributed and federated manner, being able to distribute analytic functionality across servers across your organization and outside of the organization. And finally, BDA is also systemic in mining and flagging this significant amount of data for other uses and further analysis. So what are the enablers of BDA? With all these new sources of data, what new technologies have evolved to process and manage these data? I think it's important to note that BDA is not based on one overall architecture or solution. It has evolved from a variety of different frameworks and different perspectives. So first off are some key frameworks. So Hadoop and MapReduce are sort of two key frameworks that have evolved. MapReduce was developed by Google in 2004 and is really a framework for processing, generating, and indexing large sets of search data that they needed to manage on the web or the internet. Hadoop was developed by Yahoo in 2005 and was created as a distributed platform for processing large sets of data. So these two frameworks really together are now available to other industries via concepts like open source and are being used by most, if not all, software vendors and products that are being developed in this space. The other framework is something called data streaming. So the data streaming is really real-time data messaging and processing. There's sort of two frameworks that exist now. One is called Storm. So it was born in Twitter and was developed for real-time distributed processing. Storm really does for real-time processing what Hadoop has done and MapReduce have done for batch processing of big data. And Storm, was developed in an environment where in Twitter, typically you're talking about 140 million tweets per day, and this number is growing increasingly. The other framework is something called Kafka. So it's a messaging system originally developed at Linked. It's an example of a complex event processing, CEP, real-time messaging system. It's used by Groupon and Weather Channel and large organizations like that are really looking at monitoring in near real time some key events across the country or across the world. The final set of enablers to big data are some key players and more mature products that are being used collaboratively by industry and vendors for developing solutions. The examples of these are an open source data mining framework and natural language processing framework, where vendors are incorporating these components into their solutions and software. Also, but not least, cloud is enabling a lot of new deployments, software as a service, and even analytics in the cloud as an enabler for big data analytics. So specific to healthcare, what are these new data sources that are growing and growing? They're both new types of data as well as increasing amounts of existing and unstructured or text-based data that have become usable by big data analytics. So the first three, genomic data, stream data, and web and social networking-based data, these are really, for healthcare, these are really, represent three new types of data that are being made available for use by stakeholders in healthcare. The next three, public health publications, clinical reference data, clinical data, which is 80% of the healthcare data that's unstructured, business, organizational, and external data. These next three are really different types of data, more of a variety of data that maybe previously existed, but until now, no real mechanism was available to handle them from a processing or even an analytics perspective. And they do continue to grow both within and outside the organization. I think a key thing that we want to mention and that we hope is clear in the paper is that, while there's many sources of big data within the healthcare sector, we feel that it's unrealistic to assume that all data will be put for use for big data analytics. And that's due to a range of governance, privacy, operational, technical, as well as funding considerations will determine what data really gets used for big data analytics. So Infoway's research on the economic side of big data, specific to healthcare, really points to much promise, both within Canada and outside of Canada, specifically the U.S. Significant high expectations and lots of hype in the IT and other industries, and in healthcare industry specifically also. And agreement, I think, from a lot of industry analysts that big data has the potential to really provide new insights and additional value to what we do today in healthcare. The slide that you see points to one key piece of research that we've come across. That is a McKinsey Global Institute paper produced in November 2011. Their study really looked at, across healthcare, government services, retail, and manufacturing. They estimated that big data analytics could improve productivity between 0.5% and 1% annually. So they're specific to healthcare. Their study estimated that for the healthcare system, big data analytics could generate $300 billion in potential value over the next 3 to 5 years if used effectively and creatively to drive efficiency and quality. So I just wanted to highlight specifically for healthcare big data analytics. There's a couple of numbers that are very important to notice. For research and development, and this gets mostly around personalized care, individualized medicine, they forecasted between $25 billion and $82 billion annually. For clinical operations, e.g. Clinical decision support, the transparent use of these varieties of data, they forecasted that potential value or forecasted estimates could be $165 billion annually. So the economics, at least for what could happen in the U.S., are quite astounding. In terms of the current state of BDA in Canada, our research indicates that progress in Canada has been slow. Little evidence of specific work being completed or documented benefits existing, and that BDA is still very much at its infancy or embryonic in Canada. And again, there's a few reasons for this. BDA is still on the periphery of healthcare, so it's mostly in the research studies or research area, or we're just getting into the research area for big data analytics, and it's not yet in mainstream practice. BDA is still unproven. Again, a lot of hype. Much of BDA still needs to be proven or documented. And there probably isn't really any production-ready BDA solutions for healthcare yet. And then finally, for healthcare, I think specifically for healthcare, there's a lot of dialogue, I think, and discussion that needs to go on around governance as far as what are the appropriate uses of big data analytics and what are the implications and considerations that we need to have for privacy and security that may be slowing down the adoption in healthcare. I think finally, there's also just generally an IDC report indicated that typically Canada is slow in adoption of BDA concepts. We tend to be risk adverse than other countries. We tend to lag behind in technology investments, and Canada is starting late and doesn't really have a key approach to how big data analytics should be handled. There are a few assertions from ourselves as far as why the progress has been slow. There's been a big focus in Canada on the last decade on digitizing points of service. And the other perspective is Canadian healthcare organizations are small, and few exist that really have the financial scale to fund a BDA program. So the next set of slides provide some examples of what the opportunities, hopefully what the opportunities are for BDA in Canada as well as outside of Canada. The first example here is an example of Google Org Flu, which has launched in 2008. So the big data that they're using is each week millions of users around the world search the internet for health information online. The functionality or scope of the solution is it possible to align people's searches from a healthcare specific area to predict potential disease outbreaks. The analytics on big data gathers this information for where people search, uses IP addresses from server logs to determine the origin of the queries, and then estimates how much flu is circulating in different countries and regions around the world, determining flu activity levels from intense to minimal, and also comparing it with current estimates and official historic information for the various regions. The outcomes of the analytics is the ability to detect outbreaks of influenza weekly. And this really complements conventional disease percent control or prevention surveillance systems. And again, this comes back to, BDA is not really seen as replacing traditional systems or small data analytics. It's really complementary to these existing mechanisms, and will complement in helping improve the ability to detect disease outbreaks earlier. I think another point, too, is as this system consumes more and more information and digests more information, the system will get smarter and therefore produce higher quality predictions. The next example is a Canadian example, a project called Artemis, out of sick kids in Toronto. The big data that they're using is data from monitors that are attached to premature babies. So over 1,000 recordings per second of measures such as body temperature, heart rate, respiratory rate, blood pressure, et cetera, et cetera. And the functionality and scope of the solution is they saw that hospital-acquired infections are a serious issue for premature babies. Premature babies have immune systems that are both immature and inexperienced, and diseases like late-onset neonatal sepsis can be particularly deadly unless doctors and nurses act fast. So the analytics that's performed on the big data is real-time analytics and algorithms that predict when a baby is at risk of infection. And these algorithms can detect subtle changes in measures captured in real time. And the outcomes are really alerts that are generated to physicians of a potential life-threatening infection before, hopefully, the child shows signs of illness. So by looking for patterns that can detect the onset of the serious disease, and by intervening an hour earlier, it can hopefully or potentially improve outcomes dramatically. So the baby's condition, the family, and potentially, hopefully, shorter hospital stays and reduced cost of the health system. Just a couple of notes. They created their algorithms. I think they're in the point where they're looking at how it performs and using that information to fine-tune it. I think this example is a good intersection of where science and medicine are coming together. The project brings together clinical knowledge and expertise with device-generated data to produce a better result. The system's outputs are based on algorithms developed in collaboration between clinicians themselves and the programmers. The next example is the Memorial Sloan Kettering Cancer Center, where they have a question and answer solution. So this solution, the big data that they're using is a massive database, which contains everything that's happened to all of their patients over 20 years. And in addition to this, they also are looking at the 90% of the world's data that's been created in the last 2 years, and the concept that 80% of that data is unstructured. And a significant amount of this data is also medical journals, large amounts of research papers, and guidelines. So the functionality or scope of the solution was that, this amount of information and massive collection is far too much paper for any one human, clinician, or anybody to read. In addition, I think the other challenge that they had was that there's approximately 2,000 order sets to pull from when choosing a cancer treatment, making it difficult or challenging to find the best fit for each patient, and it's not an easy task. So the analytics that they performed on big data is they leveraged Watson, which is a cloud-based analytics service, which uses proprietary algorithms as components that plug into the Memorial framework. And these algorithms analyze millions of pages of unstructured text in patient records and medical literature to locate the most relevant answers to diagnostic and treatment-related questions from the clinicians. So it pulls out relevant terms to match the search terms in the clinician's query, and also understands and can interpret the expressions within the English language. So the outcomes of the analytics are better care for patients by following the protocol and then coming back with a list of diagnostic and treatment options for physicians to choose from, with the confidence ratings of each of the options. And I think the key point here is that, the analytics doesn't replace the clinician. It really complements the clinician's knowledge and expertise, provides them with a ranked set of options and treatment considerations for the clinician to make a decision on. The next example is Seton Healthcare family and their natural language processing solution. So the big data that they're using is just 80% of the healthcare data that they have is unstructured and consists of physician notes, registration forms, discharge summaries, and other medical documents. The functionality or scope of the solution is they're really driven by a problem where they've got 500,000 new cases for chronic heart failure diagnosed every year, and more than half of these patients are readmitted within 6 months after the treatment. So they're really looking for a way to reduce readmissions for patients with congestive heart failure, as it was costly to Seton, as well as costly to the U.S. health system, to a tune of, I think, an estimated $35 billion a year in the States. So the analytics that they've done on big data is to mine this unstructured data using natural language processing and search technologies, which predict which patients are at most risk for readmission based on identifying known risk factors, examples being smoking. And when combined with structured data, the tools paint a more accurate picture of what the trends, patterns, deviations, allowing clinicians to make better informed treatment decisions. I think just some of the outcomes that they've seen around analytics is data was found in the history and the physical part of the medical record in narrative sections that helped them identify at-risk patients, and I believe they also found some interesting results which they didn't expect when predicting the probability of a person's readmission to a hospital. The last example is around personalized care at Mount Sinai Medical Center in New York City around cancer care and genomics. So the big data that's being used is large sets of human gene variations, sequencing and biomarkers that are available to be used by the health system. The functionality and scope of their solution is based around what they call BioMe platform, so personalized medicine, where they enrolled 25,000 people to participate in this program, each patient consenting to DNA sequencing and the longitudinal records related to their data being embedded in their electronic medical records. And the analytics on this data is, their warehouse contains a wealth of data, including the data in their EHR and EMR, as well as the data that comes through the gene sequencing for diseases and medically relevant traits. So they're able to identify and develop additional biomarkers using the existing clinical information from the warehouse in a reduced effort, time, and cost manner, as well as provide some early detection and improved treatments based on genetics and combining genetics and patient data. So the outcome of the analytics is they're able to help give patients more targeted care through a clinical decision support engine, which delivers guidelines which considers genetic variants of clinical significance informed by the patient's gene sequencing, as well as other longitudinal clinical data sourced from their electronic health record. I think the paper hopefully also provides a realistic perspective that, big data is great, but there's also a lot of considerations that stakeholders need to take into account around managing risks, removing barriers, challenges, and creating enablers. So big data analytics is not just about the data or the technology. It's about governance, people, organization, culture, new processes of innovation, and knowledge creation, accompanied by a whole range of enablers. And all of these that are listed are important and key considerations, so I won't go through all of them, but I'll pick on a few. Business model, some of the questions that need to be looked at or answered are, so what is the business model and sustainability model for this look like? Do I, as a stakeholder or Canada, need in-house or cloud services-based model? Is there going to be one or many of these types of solutions? Is it by use case? Is it by discipline? So will there be solutions that are specific to cancer, specific to a specific disease? Do these solutions need to operate across regions? Do these solutions need to operate across jurisdictions? So a lot of considerations that need to be thought about from the business model. On the governance side, the key question that I think people will be starting to think about is, so what are the appropriate uses of PHI data for big data analytics? What are the impacts on existing processes? What does this distributed framework mean to my governance and risk frameworks? Are there changes required? Who will own, operate, and govern BDA concepts like personalized methods, streaming sensor and device data, and internet and social media data? On the leadership side, so we've heard that you've heard that Canada is behind and needs to get started now. So we should start hopefully seeing people looking at how does BDA align with my IT vision, with my health analytics strategy? Do I have a culture of sharing and learning within my organization? Is there a will to make this happen in my organization if we find the right use cases? And something I think that maybe most people are aware of too would be skilled resources. Is there, there's already a skills shortage in the data scientist role across the world. So where do we find these resources? How do we train these resources? Do our managers and existing business analysts require new skill sets, additional training around being able to use and leverage big data analytics? So, what does Canada really need to do when it comes to skilled resources? What are we planning to do as an organization? Do we need to start planning and having discussions with our local educators that we work with, or that we're close to, or that we look for skilled resources with, to make sure that we're moving forward with trying to address this gap that exists across the world. So there's a few predictions that I think Infoway gives in the paper. So over the next couple of years, we expect to see, again, cautious, research-based experimentation will continue, focused on cancer care and genomics, personalized care and individualized medicine. But we also think that, just due to the overwhelming amount of data that is now available in healthcare, we expect to see some predictive mining, data mining or analytic solutions for personalized care that give real time to highlight best practice treatments to patients. We also expect to see clinical decision support type solutions, which again offer early detection and diagnosis before a patient maybe develops disease symptoms or are targeted to a specific use case. And we would also expect from a streaming or data streaming or monitoring of data, some solutions to maybe evolve in the home monitoring space, where by predicting and keeping patients at home through analytics, we can again reduce the amount of hospital visits or even reduce the amount of visits to ER. And I think finally, we'll start seeing maybe a few of the other existing vendors or legacy vendors start looking at trying to incorporate BDA-type applications on top of existing clinical decision support or point-of-service systems to create some new capabilities in their products, active learning, predictive analytics on top of some of the foundational infrastructure, so that they can derive some additional value for their stakeholders that may not otherwise been available to them in the past. Some predictions around BDA readiness, so which stakeholders may be ready to start moving towards BDA. I think as mentioned earlier, we believe the larger health delivery organizations are ready for BDA, and in particular those with the research base, so academic ties, maybe access to clinical leaders, some access to key skill sets and key resources. Organizations that have advanced a level of maturity, maybe within their EHRS, within their small data or data warehouse and business intelligence environments, and maybe they have some established centralized data sets that they can start leveraging and integrating with concepts like big data analytics and access to the toolkits that they need to do that. And then finally, established information governance capabilities. So organizations with sound data quality practices, sound data management frameworks, have the expertise, are aligned with key partners, and have the skilled resources. These are probably organizations that can start moving forward. I think another perspective, too, on the readiness side is health delivery organizations that have demonstrated some practical or early success with concepts like knowledge management are ready to take the leap to BDA. So these organizations have a good understanding of knowledge management concepts, knowledge discovery, and these concepts are very similar to what's incorporated or coming with big data analytics. So our call to action is really a suggested set of approaches, sequencing, or activities to help hopefully move the big data analytics agenda forward. From a communications perspective, really identify, organizations hopefully can identify champions, and those champions, look to find champions from the clinical, business, and technical side, and invest where you can in their learning for BDA. Conduct due diligence around big data analytics to understand what it is and also what its impacts may be on me, and then how it fits into my e-health strategy. And then share any research lessons learned from some initial investigation or work, pilots, or BDA work that you're aware of elsewhere. So, I think the idea is to share as much as you can and share that with other organizations and people. The next sort of set of activities is looking for opportunities to collaborate. So, we're suggesting don't do it alone or don't start from scratch. Look for private, public partnerships, research opportunities, form partnerships with peers, trusted organizations that have common interest, experience, and may even have some BDA solutions and services available. Leverage work done elsewhere, particularly internationally, and collaborate on use cases, business cases, and benefits. And where possible, leverage BDA research agenda in Canada, especially as it relates to healthcare. On the leadership side, it's really, start looking at assessing and understanding how to leverage some of the existing investments that you've made in digital health or EHRS, and have also made maybe in health analytics. Assess and address maybe pilot, policy, legal, ethics, business model, sharing, or legacy issues that maybe you think are critical for some of the initial pilots that you want to do, or maybe that you see as barriers to being able to be successful with a key use case that you want to go forward with. Look for opportunities where innovative technologies can come together. So a good example of that is, if you're trying to do something with cloud computing, if you're trying to do something with mobile health, with remote patient monitoring, then maybe big data analytics can provide a component of that solution, and you can prove two or multiple things at the same time. And then finally, for the leadership, is enable a culture that supports BDA. The last set of activities is really recommendations around cautious execution, limited scope pilots, et cetera, and focus initial efforts on developing and adapting use cases, business cases, and strategies and roadmaps. In summary, some of the key messages to leave with you. Big data analytics is not the same as small data analytics. These are two different types of analytics and tool sets, and really should be seen as complementary. With big data analytics, we're starting to see the application of science to medicine, so personalized care and genomics, natural language processing. You know, there's just so much information out there that the human eye can't manage. So we're looking at, you know, having to depend on technology a lot more and incorporate that into the things that we do know. It's not all just about data or IT. I think I mentioned this before. It won't be easy. There are many things to consider. You know, big data analytics is really, you know, 5 to 10 years out in Canada. If we don't start working on this now and we wait too long, we could possibly miss some great opportunities for creating some additional value in Canada around healthcare. Governance is all around the appropriate, you know, what is the appropriate use of patient information? What is the transparent and open discussion that needs to happen where, you know, what BDA benefits patient and the health system and what the various enablers are. And I think I'll close off with on the skills shortage side. If you are someone looking for opportunities to expand your career, you know, maybe now's the time to start getting interested in BDA. If you're an educator, start building, you know, are you starting to build a curriculum specific for healthcare? If you're a ministry, you know, do your internal resources have the skill levels to move to this next step? So hopefully Canada is going to start looking at doing something and moving towards addressing this gap.
That was fantastic, Alex. Thank you very much. That was a very informative presentation on a very complex topic and one that is emerging and changing very fast. So we'll open it up to questions. Just a reminder, go to the floating toolbar at the top of your screen, click on the down arrow and select the menu item that says Q&A and type in your question there. And we've got some very interesting ones here, Alex, so I'm going to pick off a few and take some myself and give some to you. But the first one is for you, and it goes like this. Our traditional data sets can be viewed as untapped resources. Can we apply BDA to some of those traditional data sets and find new discoveries or patterns in those data? What are your thoughts?
I think my thoughts are definitely, I think BDA is really about, you know, bringing these different types of data together and leveraging some, you know, capabilities around natural language processing and predictive analytics to provide some insights and new insights into, you know, what didn't we previously think about, or what were we not able to look at or consider just because of the amount of data that's out there that we're, you know, the human eye and the human brain just can't go through. So I think, you know, there's definitely opportunities. I think, you know, from a big data perspective, if somebody's doing some things with small data, you know, it's probably good to maybe think about how can I do a little bit of a pilot or an experimentation with big data analytics to see how much additional value would that bring to me if I'm rolling out a small data analytics solution. Again, making sure that, you know, we try and minimize the risk and initial investment and make it more of an experimentation approach to prove some initial concepts around big data analytics and the value.
This next question is somewhat related to that one. In a sense, we've got a lot of data sources from the EHR, for example, from point-of-service systems, from patient portals and personal health records, and even telemonitoring data. So a big mix of different data sources, a lot of variety, a lot of volume, as you would call the 3 Vs. Can we use BDA to analyze or utilize data from these variety of sources?
I still think, at least initially, that these two capabilities or technologies are going to coexist. So, you know, depending on the question that somebody is trying to answer, you'll need to, you know, model for the known questions and things that you're trying to answer. And then, again, if the question is more exploratory, then, again, maybe that's where the BDA perspective can come in and leverage the BDA capabilities to mine some of that information and again take advantage of some of the additional sources that may come from big data analytics.
This next one I'll actually take. It's around BDA and IBM's Watson. I've looked at Watson probably more than anyone else in the group, and so how do this topic and this particular solution or technology compare? It's actually a little bit of everything Alex pointed out. It's a bit on the framework side, a bit on the analytics side as well. So when you look at something like Watson, it's a very complex solution that in part is one of the frameworks, such as natural language processing. It's also capable of accessing and utilizing very large and broad, deep knowledge bases, which Alex also pointed out as being a source of information. But it's also an analytic and learning system in that same context. So is it applying BDA concepts? Yes, to healthcare, but it's also one of the enabling tools with its own frameworks that will make more of this capability possible, and it's actually behind one of the solutions that Alex pointed out in the use cases earlier. Another question, Alex, is around, this all sounds very complex. We're just getting into small data analytics. Where do you recommend we start on our journey with BDA?
Well, I think the feeling that I would have is, again, focus on doing some research, find out what other organizations or peers are doing, what other countries are doing, identify, one or two, key use cases, and then for those use cases, start looking at a strategy for, how does that use case align with my overall IT strategy or my overall analytics strategy, and start piloting or experimenting with that use case to try and minimize the investment, but start getting into documenting, so what do we expect to see from a benefits or return on investment perspective.
A couple of questions here on skill sets and training and improving one's skill sets. What do you recommend for folks in that context of improving their own skills and addressing, if I'm on the other side, maybe a manager or a healthcare delivery organization, addressing the skills gap in Canada for my own staff?
Well, I think probably on the skills side, there's probably, I think, some capabilities evolving. And I'm not aware of anything evolving in Canada yet, but there's probably some capabilities evolving outside of Canada. So in the U.S., I think there's quite a few curriculums that are being created. So there might be opportunities for somebody that's interested in learning more or just doing some exploratory education themselves to get involved in some of those things. I think there's all kinds of events happening around big data analytics, and there's a variety of organizations that are out there that monitor these events. So you could, if you're just, again, interested in trying to size up what this is all about and get a brief introduction and even a couple of days of exposure to it, there are organizations that have focused events around big data analytics and provide training around big data analytics and solutions.
Okay, another one is really a clarification question. You had mentioned internal data sources primarily in the small data and analytics area, and then these external data sources primarily in the big data area. Can you really clarify the difference between what you meant by internal versus external?
Well, I think on the traditional small data or traditional analytics, when I talk about internal data or enterprise data, it's really data that's known, that has to be modeled, that has to be organized in order to get into the analytics environment or repository. So in most cases, that's information that's within the control of the organization, and maybe it might be a little bit outside of that organization because maybe it's partner data or things around the supply chain or things like that. Versus, I mean, to me, the difference with big data analytics is you can now with big data analytics and the concepts that are coming with it, and these are some of the frameworks and enablers around culture of innovation. There is data that can be mined from outside of the organization, whether it's environmental data, whether it's open data that maybe exists at a federal level, or exists maybe somewhere that can be again integrated from outside into this new environment to again add just a different perspective, whether it's weather, whether it's socioeconomic information, whether it's environmental information.
Okay, there's a question here primarily around standards, which I'll take, Alex, and it's kind of a two-parter. One aspect of it was around HL7, and the other aspect was around controlled medical vocabulary, such as SNOMED CT. And I'll start with the controlled medical vocabulary perspective. As Alex pointed out, up to 80% of healthcare data can be free text, but where appropriate and where needed, a lot of that data is structured and discrete data, and where it can be coded would provide a lot more value in the analytics perspective, and coded with things like SNOMED CT or LOINC would be very beneficial to the algorithm. As far as HL7 is concerned, it's not really in play in this kind of context, especially when you're using extract, transform, and load tools in the more traditional data warehousing analytics area. Certainly not in the big data area, but I would say even though HL7 as a messaging or document standard is not in play, the information models underneath those technologies are aspects of the data, typically more structured and maybe even coded, that would play a very key role in building these repositories, data warehouses, and doing the analytics in that context. And then one last question, Alex, and we'll wrap it up. How does business intelligence fit into BDA?
I think I've indicated that my feeling for business intelligence is it's really, those are the traditional data analytics. So business intelligence and data warehousing are what I call small, or what's now being called small data analytics. And again, it's called small data analytics more because in healthcare there really hasn't been movement forward or as much adoption as possible across the enterprise. So business intelligence really to me is something that BDA can feed for mining a lot of the information that maybe we haven't identified relationships or potential use for, and then that information can then be fed or integrated into a business intelligence environment where, again, once we get into that environment, the data needs to be a little bit more structured, organized, and aggregated for analytics use.
Great, thank you. If you could move to the next slide, Alex, we'll wrap it up. Just want to remind folks that we will be sending out by email a evaluation. We would encourage you to fill out that evaluation. After you submit that form, we'll also provide to you a link so you can download a PDF of this presentation and the link to the recording of this webinar if you care to view it again and want to share it with others. So we would encourage you to make others aware of both the papers and the availability of the presentation and the webinar. On the next slide, you'll see some links to, first of all, the Infoway website. We have a landing page to the Emerging Technology Group as a program on our website where you can get some other information, stay up to date with respect to the work that we've published, access to the downloads to that work. And if you want to reach us, there's an email that is shared by the group, so you can pose to us any queries or questions using the email that's represented there. Certainly could follow us on our blog space and through Twitter. So we want to thank you very much for joining us today. I hope you found this informative and useful, and we look forward to hearing from you. The next webinar will very likely be in the September time frame. We've got a number of topics that we are working on. We'll probably take the summer off from a webinar perspective and be back visiting with you in the early fall with some new topics. So stay tuned, watch your email and the events postings for an announcement of our next webinar in the series that will commence again in the fall. Once again, thank you very much, and have a great day.
Thank you, and have a great day.
Thank you again for joining us today. This concludes today's web conference. You may now disconnect.